Hi everyone, Professor Peter Nash from Griffith University, beautiful downtown Brisbane, reporting for Room Now, EULAR Barcelona 2025. I thought I'd just go over a couple of the oral presentations, 0092 and 93. You've heard a lot about treat to target and the STAMP study. They showed the 12-week data previously, but this is the 48-week data. And really they're comparing secukinumab 300 milligrams monthly from day one with methotrexate 50 milligrams a week and one injection 80 milligrams of triamcinolone with conventional agents, therapy standard of care like methotrexate 25 milligram a week and a triamcinolone injection. By the end of 3 months, something like 4 times as many patients had to escalate for the methotrexate, add another drug. In this instance, sulfasalazine was mandated, compared with the patients continuing on the methotrexate 17 inhibitor. And then after another 3 months, you had something like 4 times as many patients escalate from the secukinumab from the conventional agents onto a TNF with methotrexate compared to the secukinumab onto a TNF with methotrexate. If you just look at the numbers overall, there was initial benefit of secukinumab speed of onset of ACR 20, 50, 70, but by the end of 12 months, those two lines of treatment had come together because a significantly greater number of patients had escalated to a biologic from the conventional agents. The skin was superior, enthesitis was superior with the biologic from day one. So it looks like you can catch up over time. The patients aren't as well as quickly, but a lot of patients had to escalate onto a biologic, something like 27 out of 60 from the conventional group, and of course the patients beginning secukinumab straight away, something like 23 out of 60 wound up on a TNF instead of the IL17 inhibitor. The other little presentation, small numbers followed for a reasonably short period of time, but there was lots of guideline type presentations defining difficult to treat PSA, that is, failed a couple of biologic and advanced therapies, but with objective evidence of inflammation, either on imaging or on acute phase reactants, compared to those patients who are complex to manage, who have no objective evidence of inflammation, either imaging or in bloods, but who have lots of ongoing widespread pain for a number of other reasons, such as osteoarthritis, damage, fibromyalgia, etc. The implication really is that if you could identify the predictors for difficult to treat, then perhaps combination therapy might be considered early, and then you can get control and reduce to a maintenance treatment choice. At the moment, we're doing that with a small number of very difficult patients, but usually get the derms or the gastros to write one drug and we'll write the other. But this small study looked at a number of patients in a case series who had taken combinations for a variety of reasons, usually flaring skin on someone stable on joints or patients stable on skin but flaring joints. And they looked to see which ones were the safest. And it looks like there wasn't too much in the way of a safety penalty. There were some mild infections, no one needed hospitalization, and no one needed to stop their drug as a result of infection. And they're able to combine TNF with 17, TNF with 23, TNF with deucravacitinib TYK2, and with Premolast. They were able to combine JAK with those agents as well. I wouldn't be combining a TNF and a JAK. I think that's asking for infection. But the 17s, 23s, deucravacitinibs and Premolast seem to have no safety penalty when used in combination with agents like the TNFs or the JAK inhibitors. I'm sure we'll increase the use of combinations over time, Formal studies will be very difficult. Registry should be able to help. Case series of bigger numbers in patients with lots of comorbidities that would never make it into a clinical trial, followed for long periods of time, will be very instructive moving forward. And then strategy studies with combinations, inducing remission, then reducing therapy to maintenance will also be very helpful. So thanks again for your attention.